We are live now. We can go ahead.
Great, thank you, Ashok. Okay, welcome everybody. Today we are going to be talking about osteoporotic fractures and how we need to deal with them, especially in terms of surgery for these. Okay, so I think this is a problem which is increasing and is going to increase even more in the near future, and something that we really have to think about. So just start with one patient. She's a 75-year-old lady, and just a series of things that happened to her. Partly, I would say it is badly done surgery or iatrogenic, but partly osteoporotic. And it's we came to be involved in it quite late in the course, but just I'm not going to go into who did what, but you can see from the series of x-rays as to how what looks like a simple fracture ends up in a real disaster. So that was the x-ray after the first surgery. Okay, so surgeon did the surgery, thought he had fixed it although he had fixed only one pillar, but I put it in a slab, and then when he did a post-op x-ray, that's what he found. He found there was another x-ray which probably didn't notice during surgery or happened after surgery. I do not know. So to deal with this, he put in these two wires. This is what happened. The wires started migrating till one was going into the joint above. It got infected. Then he added, so Janki, can you make sure these waiting ones don't come to me?
Okay, sir.
Okay, because it comes in the middle of the slide. Then it got infected. It was debrided, then everything was removed. That's how it was looking at the end of that. Had a further debridement and thought the infection was controlled. And then he came to one of my colleagues and he called me for the surgery. So because he found there was infection again, so we debrided it thoroughly, used antibiotic cement and stabilized it. Things went well. She seemed to have healed the infection, and the idea was to replace the cement with bone graft and maybe further augment the fixation. But she came back, didn't come back in due time, but turned up 3 months later, and the infection had healed, everything was okay, but she went and fractured at the end of that. And then that was what it looked like at surgery by the time we had excised all the necrotic bone. Decided that now the only option is to really go for an arthrodesis, going across the elbow joint, double plate, came back for suture removal, and that's what it was at that stage. Okay, so it had fractured at the end of the plates again. And then we decided that we are going to now treat it conservatively, and then finally it went on to heal. But you can see the kind of problems that this lady went to, partly because of bad surgery, but also because of the osteoporosis. And this is a problem we are going to be seeing again and again, and in various forms. It's related to the increasing longevity of people worldwide, thus leading to people having osteoporosis, leading to increased osteoporotic fractures. And there are many reasons for it apart from the osteoporosis. It's with age. People tend to lose their balance. They're on medicines which may alter their cognition, etc. So the reasons for the fractures are many, which you need to take into account when you're treating these patients. And it's a huge burden on resources. And I mean, you just need to look into some of the literature to see the kind of burden on healthcare that osteoporotic fractures cause, and what are the major challenges to the fixation of these fractures. Now, I'm not going to go to details of osteoporosis or definition, but basically what happens is that the bone becomes weaker. The holes between tissue in a way become bigger, making it fragile and liable to break easily, okay? It also leads to a decreased thickness in the cortex, okay? And Partly this leads to an increased diameter of the bone to maintain stiffness. Okay, so there's a reactive kind of increase in the diameter of bone, but the cortex becomes thinner. Also in the cancellous bone, there's less and thinner trabeculae with fewer often broken interconnections. So all these changes occur both in the cortical and cancellous bone, uh, causing the bone to become susceptible to fractures. Okay. The other problem that happens with it is that your fixation doesn't hold as well as it would do in good quality bone. And the studies show that osteoporotic, there's a tenfold reduction in pull-out strength of screws between the ages of 50 and 80. So as you get older, the pull-out strength of screws decreases significantly. Now, in terms of the biomechanics of bone failure and fracture repair, I think micro movement doesn't change. Callus response doesn't really change, but uh, the implant fixation is definitely compromised and the stability under load may be compromised. So as you can see that it's not the biology that is an issue, but the implant fixation is, and you can get multiple complications such as failures of fixation, secondary loss of reduction, and iatrogenic fractures. And you can get peri-implant fractures. And all of these were seen in that case we showed. And we keep seeing disasters such as these that we have to deal with. When you are doing secondary surgery on these patients, it actually becomes even more difficult to deal with them. The other thing we see increasingly are periprosthetic fractures. So patients who've had a total knee replacement or a hip replacement, partial or total, and then they have with a minor fall or stumble, they end up fracturing close to the implants and making the fixation even more difficult. You also need to see if the implant is stable or not. Now, what are your strategies of fixation? Now, you can see what we discussed earlier, how with osteoporosis, the cortex really thins and the diameter of the bone in trying to sort of increase the strength of the bone also increases, okay? But you can see how thin the cortex is and obviously the bone is liable to to failure, and you can imagine that screws are not going to hold very well. Now, before the advent of lock plates, this is a case way back, so it's more than 20 years old, where before really interlocking nails were very sort of widely available. And here we actually used a K-nail, but you can see the size of puncture nail that we use. It's a huge size, I think 17 millimeter nail, which would give you adequate stability, and the fracture actually went on to heal well. So that was one option, is to use nails rather than plates and use thick nails, wide diameter nails, which gave you a better stability. When you were fixing with plates with these osteoporotic bones, especially with the conventional plates, there were various things you could use. You could use cancellous bone or cement augmentation. So you can see in this case, these screws have been augmented with bone cement. We've used this cancellous screw here because the cortical screw was not holding very well. And we could get this fracture to heal, but obviously makes the fixation more tricky and more difficult, and the risk of failure becomes much higher. Similarly, something like this, where a patient had a proximal femur fracture, which was treated conservatively, went on to non-union as well as a deformity. Now, if you had to try and salvage this hip rather than a replacement, you really have to be worried about your fixation in this area. So with the conventional DHS, what we did was we did an osteotomy to get the angle right, and we also augmented the DHS fixation with bone cement. Okay, and you can see how nicely this has then gone on to heal. Of course, you have to be careful that you've not drilled or across the head so that the cement goes into the sort of joint. So that's something you have to be aware. But this holds the implant really well, and you can see how within 3 months this has gone on to heal. And you can see the quality of bone has also improved with him being able to put weight on it. Another way to sort of help you with your fixation is, this is a patient who had a infected non-union and then multiple surgeries before the infection was controlled, and by that time his bone was quite osteoporotic. So we used an angle blade plate, but then we also augmented it with an external fixation to make sure that the stress on the implant was reduced, because the proximal fragment was quite small, and this actually went on to heal as well. You have to be careful in your surgical strategy, and this is from Chris Vanderwerken, how when you use a clamp, you can actually crush the bone. This originally only had this fracture, but during surgery, the clamp caused a second fracture, and so the fixation had to go across this second fracture as well. So be careful with your instruments. Don't hold the bone with clamps in such a way that you crush the bone and further cause problems to your fixation. Of course, with the advent of lock plates, things have improved significantly in our ability to fix them with plates. Okay, there are various factors which come in, but as far as osteoporotic bone is concerned, is the angular stability of the screws. The fact that the screws are locked onto the plates means all the screws on one side of the fracture have to loosen before they can come out. Okay, so that's one of the factors, and the fact that especially in the metaphyseal plates, these screws are in different directions, makes it an advantage to fix these fractures. Now, we can have various examples of this. When you're dealing with proximal femur fractures, I think getting the valgus angle right, getting the fragments impacted are all critical factors. But again, if you have locking screws, and this is a DHS with a locking screw, so LCP DHS, which allows you to put in some locking screws in the shaft here. It also has a helical blade. We have used the screw in this particular case, but we also use the helical blade here, which gives you a better hold in osteoporotic bone. And the locking screws give you a better hold on the shaft fracture. And you can see how this has gone on to heal. Maybe slight medialization, but has gone on to heal quite well. That's a final follow-up X-ray. These certain principles, again, that you need to follow. One of the things is to use long plates so that you increase the lever arm and therefore improve the pull-out strength. You need to plan your fixation as to not put in too many screws into a small area so that there's stress concentration. In osteoporotic bone, lag screws don't work because if you try to tighten the lag screw, they're just going to spin loose and therefore not work. So these are various factors that you need to look into when you're dealing with osteoporotic fractures and fixing them with plates, where using long plates becomes an advantage, using angle stable plates is an advantage, and planning your screw fixation in a way that you distribute the stress adequately, bridge the fracture, makes a huge difference to your ability to treat these fractures successfully. So on the other side, that was a distal femur. Even on the proximal femur, with these comminuted fractures, sometimes nailing can be really difficult, but you can bridge these fractures using minimally invasive wiring techniques and a long plate, which sort of gives you a long lever arm as well as distributes the stress sort of over a wide area, and therefore reduces the stresses on the implant as well as on the fracture. And you can see how this is going on to heal well with callus, because this is a sort of relative stability concept. The other way of increasing your fixation is to augment plates. So even with a locking plate, sometimes if the bone is so osteoporotic, this lady had 3 previous fixations which failed. And so when we had to do it, we put this long locking plate on one side and then an orthogonal smaller plate, which kind of made the fixation more secure. This is her at follow-up. You can see how nicely she's gone on to heal the fracture with, again, a good function as well. The other option is to use an intramedullary fibula. If you see this lady who came to us 6 years after the injury, and you can see the head there's hardly any bone now. Screws in this, even with locked screws, you'll be worried about the fixation. But putting an intramedullary fibula into this and putting some of your screws through the fibula into the head greatly increases your fixation. So you can see this screw goes through the fibula into the head. One of these screws is also going to the fibula, and again screws in the shaft go through the fibula. So you can see how this will give you a really secure fixation. You also need to get the valgus right. You need to bone graft. You need to make sure there's no medial defect, which again would stress your implant. And again, you can see within 4 months, this fracture has gone on to heal with a good function in a lady who hadn't used that arm for 6 years. Similarly here in the distal femur, a very distal fracture, 80-year-old lady, and some people would actually say that the only thing you can do for this is a total knee replacement. But again, as long as you have some bone, you need to get your CT, follow it very carefully. And as long as you have some bone, even if it's a shell of bone, you can see what it looks like at surgery. But with this intramedullary fibula in place, you can reconstruct it, put in your wires, put in your locked plate, using screws going through the fibula in this area. So this area, all these screws, as many as possible, go through the fibula, and this is a plate with polyaxial locking screws, and you can see how this is going on to heal well. This is at about 6 weeks, and she's from somewhere near Delhi, and she hasn't come back for follow-up, but her son is nearby, and he says she's doing well as well. Okay, that was the final, I think, at about 2 months. So one of the things with locked screws is if they're all the same direction, the chances of pull-out increases. So if you're dealing with bones that are so sort of osteoporotic, and this was actually a young man, but he had an open fracture which was initially treated with sort of an external fixator. Then I think he had an Ilizarov, then plastered. So by the time he came to us more than a year down the line, you can see how osteoporotic his bone was and how thin his cortices were. And here, with the lock plate, you can actually bend the plate so that your lock screws are in slightly different directions. So that again will increase the pull-out strength of your plate. Okay, so this is not easy to do, but you can do it by putting in some sleeves into the holes that you want to put your lock screws in and bend it in between them. Okay, so this is what we did. We also used a cortical iliac crest graft on the opposite side. So this screw and screw across it to press across the fracture. You can see that, and then the locking screws going in slightly different directions because of the bending of the plate. And you can see how this has gone on to heal nicely. This is at about 4 months after the fixation. You also have these special devices. This is known as a LCP attachment plate, which is, we call it the spider plate, which you can put onto a locking plate, fix that with a screw to the plate, and then you can put your screws in different directions through this extension in the plate. So especially for periprosthetic fractures or peri-implant fractures in the region of the implant where you can't put in screws in the direction you want to, you can change the direction, put multiple short screws within a short area. So here's a lady we had treated with a gamma nail many years ago. I think this was in 2007, and she came back in 2014 with this peri-implant fracture, and you can see how this actually extends a long way down. But in this area, it's a problem getting adequate screws, and so this plate attachment which we put on, and then we can put in screws, locking screws into this in different directions. So this is how we fixed it. Also added some circlage wires, and you can see how this has now gone on to heal well. So you can see how nicely this has gone on to heal, and now hopefully she can't fracture this bone again. She can fracture something else for sure, but hopefully this bone is not, there's no place for this to fracture from again. You sometimes get these hypertrophic non-unions in these osteoporotic bones where this was nailed, was obviously unstable, the nail was removed. And here you can compress across this. If you can get a lag screw, or you put a compression across it and use your lock plate with your locking screws, And you can see how nicely this will then go on to heal, because with the stability that these long plates with lock screws give you, you can mobilize these patients. And once they start weight bearing, you can see how the quality of the bone also improves with time. Now, the more recent nails from the AO, the trochanteric femoral nail, also has this ability where you can have both screws as well as a helical blade, and even through this, you can actually put in cement. So you fix it, and if you're worried about your bone qualities, which is really poor, you can actually inject some cement into this area, which will then increase the stability of your fixation. We talked about periprosthetic fractures, and this is another problem that we are going to deal with. And if you look at it, you can see that how osteoporotic the bone is. It's a very distal fracture. The knee as such was okay. So you get your CT scan, and these are the distal femur fractures where very often you may prefer to put two plates. You can see there's a medial beak, posteromedial beak to it going quite more proximally. So we actually buttressed that with this T plate at this posteromedial corner, and then used a long LCP to bridge the main fracture area. So this gives you a very good fixation, stable fixation, and you can see how this, you can start early weight bearing, and you can see how 6 months this has gone on to heal well. Similarly, you can get periprosthetic fractures around a total hip replacement. And again, if the implant is stable, you would try to fix it. Again, locking plates have helped. You have special screws for periprosthetic fractures, which are shorter with blunt tips, locked screws, which you can use so that you can get a good hold on the cortex without having to go well across the cortex as you have to do with conventional plates. This gentleman had a primary hemiarthroplasty for a trochanteric fracture elsewhere. So this is another thing that you have to be careful of. This has become a bit of a trend sometimes to rather replace rather than try and fix these fractures, and you have to weigh your options very carefully before you do it, because that in itself you may get the patient up earlier as compared to a fixation, but in real terms, if you get a good fixation, you can get them up just as well and just as soon. And if you have a periprosthetic fracture, it's a disaster, and we have to then replace it with a longer uncemented solution stem with added wires to get him moving. And he was a very elderly gentleman. We were able to mobilize him, and he left the hospital, but we haven't traced him for follow-up, so I'm not sure how he's doing at the moment. So I think in summary, osteoporosis does not impair fracture healing, but certainly as you can see in the cortex is the cortex, which is really thinned out. Well, in the metaphyseal area, it's the sort of cancellous bone and the trabeculae, which become much more osteoporotic and thinner and weaker to hold screws. I think you need to plan your surgical treatment carefully and decide on various things, your reduction, your fixation, whether you're going to bridge, whether you're going to use additional wires, circlage, etc. You have to plan your fixation so that you can get adequate fixation to be able to weight bear these patients, because it's important to also weight bear them, because it's only if you weight bear them that the osteoporosis or the quality of bone in that limb is going to improve. I think locking implants have definitely helped us. You also have to treat them for the osteoporosis with proper medication. Now, you have to decide who does that, whether you do it or the physician does it or the endocrinologist does it. But you must have a system in place where you're treating patients that it doesn't get missed out altogether, which happens very often. And today you also have the problem of atypical femoral fractures related to the medication for osteoporosis. So with bisphosphonates as well as with denosumab. Now we are seeing the atypical subtrochanteric fractures, and these are a real challenge on its own. So I think osteoporotic fractures are going to be a problem for us for the near, or in fact, for the next many years. And I'm not sure we really have a solution for it, but we have to deal with them in the best of our ability to also get the fracture to heal and also to try and prevent further fractures from taking place. I think we all see patients who had one fracture come back 6 months later with a fracture on the other side. And we have to try and not just treat the osteoporosis, but it also needs a lot of lifestyle modification, precautionary things, medical treatment to improve cognitive function, balance, restructuring of house so there are not carpets and rugs lying around where they can slip with. So there are multiple factors which really need to be taken into account to prevent these fractures from happening again and again. Thank you.
Thank you, sir. So for DNB, if some question is there, you can ask.
Yeah.
Sir, I have one question regarding if the T-score is good, sir, and someone having low trauma which causes fracture, do we call it osteoporotic fracture?
So I think if you have vertebral fracture, hip fracture, proximal humerus fracture with sort of minimal trauma, yes, then they are already osteoporotic. And because the T-scores, again, none of the scoring systems for osteoporosis are that accurate. So the moment they get clinical fractures with minimal trauma, so what we will call osteoporotic fractures, they are already osteoporotic. Okay.
Yes. In fact,
there may be a cause for the osteoporosis. You need to look at their vitamin D levels, parathyroid, make sure they're not developing or they do not have some parathyroid problem or other endocrinal problems which are responsible for it. But once they fracture with minimal trauma, they already, you don't need a T-score to say that it's an osteoporotic fracture. Okay.
And someone if have once a fracture, what are the risks of getting fracture in like up in the future, sir?
You tell me.
Like, sir, they have in the literature they have written in the first year it is more, and after that it is about 50% chance of getting fracture in the first year.
So that's a very high number.
Yeah, five times more risk. Yes, sir.
Exactly. And I don't think it stops the next year. It continues. We get patients, I mean, you've seen who've had their hip fracture fixed 4 years ago, and then they fall again and come back with a fracture on the other side. Okay, or peri-implant fracture. So I think osteoporosis never becomes normal. Okay, you can improve it, reduce the progress of it maybe, but you never cure osteoporosis. Yeah. And also with age, the cognitive functions, balance, etc., again go down. So the risk of fracture increases. So I think it's a lot of things that have to go into place to try and prevent the fractures from
happening. We tend to underestimate importance of spinal fracture usually, sir, because it is mostly unrecognized, and sometimes even on seeing the X-ray, what should be done, sir? What is our action to be taken, sir, after that? If someone is
again, if you get a vertebral fracture, okay, those are usually compression fractures with minimal trauma. It could be just riding in a car, they have a small jerk and then they have pain in the back, or so it's usually not completely asymptomatic, but they'll have sometimes minimal pain or discomfort, etc. But I think once you get a clinical, you have a fracture, then you have to treat them for osteoporosis.
Yeah. Is it anything different for if someone is having osteoporotic fracture in the vertebral region or someone is having osteoporotic fracture in the hip region? The management, right, sir?
So different in what way?
Means medication, sir. If you have some other medication for
So I think this is not about medication for osteoporosis, because I think there's so much
Yeah.
going on about that controversy, especially nowadays with combined treatments, successive treatment, whether you give them teriparatide first and then follow it up with bisphosphonates, or the other way around. Where do you use denosumab? I think that's a whole different discussion altogether.
And so, is there any harmful effect of giving more
But
vitamin
what
D?
is important, what is definitely important is mobilization. Walking is good for bones. You need to make sure the calcium intake is adequate, which in most people, especially in India, is not. So they would need supplements, and you need to make sure that they get vitamin D in adequate quantities. Because again, nobody moves around in sunlight nowadays. So you have to make sure they get some exposure to the sun, and if the vitamin D levels are low, I think you should correct them, or at least give them supplementation for it.
Is there any harmful effect of getting more vitamin D or calcium, sir? Like,
So why are you asking that question?
because sir, in OPD we are seeing many patients having vitamin D since every week for about 1 year. So for that one, sir, do we
So
have
why are they having that?
someone has prescribed and then again they go to some other doctor and then again they prescribe it?
So I think, I mean, you can't, so I think the treatment is weekly for 2 months or 3, fortnightly or monthly, okay? So I think if you give it without any rationale, then you're going to see problems, okay? Overdose with happens more with the injectables than oral medication. And if you have very high levels, then you have risks of stones, etc. Okay, so I think it's something you have to be careful of. But with proper dosage, it's very rare for these problems to happen unless they have some other metabolic problem. So it doesn't mean that you're giving patient calcium, he gets stones. The reason for the stones may be completely different. Yeah.
Okay. And so, one
What
question was they
questions from the
asked,
DNB students? I think they
is
should ask
Avinash,
questions first, yeah, rather than you asking all the questions.
actually Avinash, I asked them, he has having body ache and also
Okay.
he's there. So maybe, and
So they
Gautam
can't
is
ask.
also here. Gautam?
Who is having body aches?
Yeah, Avinash, since about 2 to 3 hours. And so one question they asked sir previously is about peak bone mass, uh, how we can prevent it, if like some advice for the parents to help their
How do you
children.
prevent it? Or how do you make sure they have
Yeah,
enough?
yeah, yes,
So, so what age do you have your peak bone mass in?
usually 25 to 30 years, sir.
Around 30 or so, huh? 30, 33 or something. So what are the things which improve your bone mass?
Usually exercise and healthy diet.
Okay, so you need to have proper diet and you need impact exercises. That means weight. So it's not, so walking will help, running will help. Just doing yoga may not help your osteoporosis. Huh? Okay, so what helps is impact exercises. Yeah.
And sir, like we have seen,
And
sir,
of course, there are many other factors like drugs. Okay. So of course, if you're steroids, smoking, alcohol, all these reduce your bone this thing.
Sir, good evening, sir.
Yeah.
Sir, sir, for periprosthetic fracture, is there apart from trauma, sir, is there a surgical technique is also responsible for that? Or?
So definitely to some extent, like I mean, if you do a total knee and you do a significant notching of the femur when your cuts, then the risk of a periprosthetic fracture there increases, although there's some controversy in the literature, but I'm sure if you look at some of the fractures, they happen exactly where you would have the notching. Second thing is, say, in a proximal, in a total hip, if your stem is not centered, it's going off to one side or impinging on the cortex lower down, then you're going to have a periprosthetic fracture, okay? So those are things in a uncemented sort of stem. During impaction, you can get a fracture, okay? So if you try to put a size too big and try to push it in too hard, you can get a fracture. Similarly, on the acetabular side, if you try to really hammer the cup in, sometimes you can get a fracture. So yes, there's relation with surgical technique for sure. But a lot of these are osteoporotic fractures which happen with minimal trauma at the end of the implant because they can't break at the implant, so they usually break just after that. Yeah.
Sir, and also in sir, prosthetic bone, after fixation, generally end of the plate, where plate ends, that portion got fractured easily.
Yeah, so that's something you have to be careful of in when you're dealing with osteoporotic bone and you're plating them. So that's why now when you're doing a distal femur fracture, the recommendation is to go quite long, right up to the region of the trochanter.
Yes.
Secondly, the last screw, there's some debate about how you put it. You can either use a conventional screw in an angled direction or sometimes use a unicortical screw as the last screw. It also matters whether your plate is centered exactly right on the bone or not, okay? So if your plate is off the center and your sort of last screw is going through the cortex, then you increase the risk of periprosthetic fractures. So then multiple factors, yes, and that's what I showed in some of the cases, that if you have problems with technique, then you obviously increase the risk significantly. But some of them happen in what looks like perfectly good fixations as well. Okay.
Yes.
So like a patient who fractures 14 years after the initial fixation, it's not the fixation that is responsible for it, but a combination of osteoporosis and the trauma that is responsible for it. But if it happens within a few days of your fixation, then definitely the fixation has something to do with it.
Yes.
Sir, one question asked in the previous year is the recent advances in treatment of osteoporotic fracture. In DNB, they have asked.
Yeah, so many of the things that we discussed, like locking screws, cement augmentation, implants with cement augmentation, bridging, long plates, how you distribute the stress, not ending, suppose you're using a double plate, not ending both the plates at the same level. All these things are factors which play a part in how you manage osteoporotic fractures, okay? And of course, prevention is again a very important part of it, okay?
You stressed more upon long plate, sir. So, like for femur, if it is a long plate, how much long it should be, sir, for osteoporotic?
So when you put a long nail, how long do you make it?
Like from the means from one end to other end.
So ideally, but it may not always be possible because you don't. So if you really look at it logically, so if you're doing a distal femur fracture and you're using, nowadays you don't obviously incise the whole area.
Yeah.
So using a long plate doesn't increase your incision. Okay. And if you go above the very bulky muscle, you actually have less muscle to go through to get to the bone in the more proximal part of the femur. Okay, so you actually may reduce your blood loss, etc. as well. But yes, these things you have to learn the techniques. Your surgical technique becomes important. You need to get trained properly to do it. It's not something you just, but I think you have to first learn conventional methods of fixation, then worry about minimally invasive techniques, etc.
Sir, one more thing I want to ask, like So
But there's a limit to how long the plate can be for various, so manufacturing reasons, whatever it is. Like we have the distal femur plate in, even with synthesis available in India only up to 13 holes. Okay, now for a really tall patient that may not reach the area of the lesser trochanter.
Sir, one related question to that, sir, but not actually from the osteoporosis. When you are doing HTO, sir, I have seen you doing HTO for 73, 74-year-old age. Also means sometimes for the osteoporotic, maybe osteoporotic bones, sir, because of the age. So after putting Tomofix, usually bone graft is not needed, as you told. So in osteoporosis, it is written, sir, to fill the bone gap usually. So you consider bone graft in those cases, sir, in elderly.
So where we've used open wedge osteotomy with the Tomofix for medial compartment osteoarthritis, so far we've never used bone graft, okay? Because your technique is such that it's a biplanar osteotomy, plus you keep the lateral cortex intact, okay? So if your technique is okay, you will not need bone graft, okay? Now, if for some reason you crack the lateral cortex or you're worried about it, put in bone graft or bone substitute. But so far we've, done more than 100 cases and we've not used bone graft in a single case where we've done open wedge osteotomy, high tibial osteotomy for medial compartment osteoarthritis. We've used it in our revision for intra-articular malunions, etc. Because there we use buttressing plates, etc. And sometimes the stress on the implant is more, and if you don't graft it, the chances of it failing are high. And you can't do a biplanar osteotomy in all of those cases. It's usually an intra-articular osteotomy. So that fragment is loose, okay? So there you would augment with bone graft in many situations if there's a significant gap. But for medial compartment osteotomy, where we do a planned osteotomy, the way we do it, following it's a standard technique. It's not our technique. We've not used bone graft now in more than, and we've had other problems. We've had patients who have not been very happy with the results, maybe 5 to 10%, but we've not had a failure of healing as yet in all these cases.
I have seen you using osteophyte sometimes, sir, for those HTUs.
Yeah, so that's something which is a very useful thing where you have significant osteophytes. If you just nibble out the osteophytes and put it into that area, somehow it seems to form bone a lot faster. Okay, those are healed in 6 weeks or something like that now. Whether those osteophytes contain a significant amount of osteogenic material like PMPs, etc., we don't know, but somehow practically it seems to make a difference in the healing time.
And
If you don't do that unless you've got osteophytes in the joint or patella which you want to remove along with your HTO. So these are where you're doing them in cases which are actually, so we are stretching the indication of the HTO. They're not ideal indications for HTO.
And so for proximal humerus fracture, like sometimes in osteoporotic bone, it is just like excel. So for fixation of those things, you use bone graft, sir, for fresh fracture.
So we have not used very often, but yeah, there may be a case where if certainly for non-unions, we use bone graft. The intramedullary fibula has been written up for even fresh fractures. Okay, for in osteoporotic bone, the Koreans have written about it, and Badman, I think, etc., have written about it, both for non-unions and fresh fractures, where you augment your fixation with an intramedullary fibula, and they use allograft, which we don't have access to, but so it's not something we want to use unless it's necessary, because it has its own morbidity. But certainly for the non-unions and Occasionally, for really osteoporotic bone, it may be worthwhile using.
And sir,
We do use, sometimes we use bone substitutes if there's a defect. But most importantly, if we get the technique right, that means we get the tuberosities back, etc. in place, we actually reduce the, and get some impaction, we reduce the gap significantly. So more often than not, we do not have to do it in fresh cases.
and so for osteoporotic fracture, the devices like sometimes nail with plate or angular fixation device we use. So probably the construct is little stiff than the normal one. So chance of non-union, is it more, sir, for that one? Or I want to ask, what is the aim of the treatment in osteoporotic if we compare it with the normal fractures?
So, like I said, it's not the fracture healing that is a problem. Okay, it is your implant hold that is a problem. Okay, so I think you have to work out your. So this is where you need to balance biology with mechanics. Okay, if you make it too rigid, you're going to have problems. Okay, but if it is not stable, you're going to have problems. So you have to try and get an adequate stability with minimal compromise to biology.
And so much is written about the PRP and bone marrow aspirate in recent time for osteoporosis. So uh, if it is in the exam also they used was, so for autologous bone marrow aspirate, uh, is it worth to use it in osteoporosis, sir?
So I think we have not used it. The only place we've used marrow aspiration or bone marrow, this thing is in where we are doing lengthening or transports for the regenerate. If there's a delay in healing, we've used it and it seems to help, but we've not used it for osteoporotic fractures. So I can't comment on that. I think the literature is also not very clear about it.
And once they have asked about RIA, sir, RIA, in that I want to know about that.
So I think this is the REMA irrigation aspirator. Okay, it's a device from the AO. Okay, and where you have a reaming system as well as a suction system with attachments to it. Okay, and so as you ream, whatever reaming materials are sucked out into a container. Okay, and this has osteogenic potential and has been, if you need a lot of bone graft, this appears to be a good method to get large quantities of bone graft. It's interesting because initially this device was developed with the idea of reducing fat embolism. That means you ream and aspirate suck out whatever you're reaming so that you don't get fat embolism. But more than that, they found that this material that they collect seems to have a good potential as bone graft. So you can get large quantities of bone graft, and it's in the West, it's become quite a popular way of bone grafting. The problem is the disposable materials, etc., are quite expensive. So in real terms, if you use things as they recommend, each time you use the system, it costs around 40 to 50,000 for the disposable material for the patient. So it becomes a little difficult to use it practically in our situation. Though we have it, we've used it, but it's difficult to use it in most patients.
Sir, one question regarding, I was watching one class on the University of Washington class. In one endocrinologist, they have said that it is about 5% of those patients which is having fracture is getting treatment for osteoporosis after osteoporotic fracture. So, sir, uh, do we can say, sir, is it a team approach and whose ownership is to start that osteoporotic medication, sir? It is.
So I think if you listen to my talk, okay, what did I say? I think you have to decide who in your team is going to treat it, whether you're going to do it or, so like in the West, very often it's the endocrinologist who does the osteoporotic treatment. Okay, it could be the physician. But in your practice or in your team, you must have a clear-cut guideline that this treatment is to be given by me or the. So it's your responsibility as the treating surgeon that the patient gets the treatment. Okay, now who gives it is a second thing altogether. Okay, who monitors it, who gives it is maybe the physician's job or the endocrinologist's job. But it's your responsibility to make sure after a patient has the osteoporotic fracture that he gets treated for osteoporosis.
So I think
Having said that, what really works for osteoporosis is hard to really quantify.
Sir, good evening, sir.
Good evening.
Sir, I have 2 or 3 questions, sir.
Yeah, sure. Waiting
One
for your
question is,
question.
yes, sir. One question is role of biochemical bone marker in management of osteoporosis.
Okay, so it's basically when you are treating these patients, okay,
Yes, sir.
so there are these markers in the urine and blood which will show you that the turnover is decreased or not, okay. In practical terms, we don't use it very often, okay.
Okay, sir. That means it is mainly used for prognosis of treatment.
Yeah, to see if the treatment is working or not, is it effective or not in reducing the turnover of bone,
Okay, sir.
osteocalcin and all.
osteocalcin and whatever they do.
One different question is, sir, treatment for unreconstructible fracture in the elderly people. Not related exactly to osteoporosis, but
So
it
it
is.
depends. So, okay, so yeah, it is, well, it is related to osteoporosis in that, say like a very bad trochanteric fracture, huh?
Yes, sir.
Now, in an elderly patient, you have to decide whether fixation is going to work or not. And there will be a small number. I think this is where sometimes we go overboard with doing an arthroplasty.
Yes,
But there will be some fractures which often have extensions into the neck in a very elderly patient with very poor quality bone. It may be better to do a arthroplasty rather than fixation. Okay.
yes, sir.
Similarly, in the elbow. Okay. So where you have a totally smashed distal humerus and a very distal fracture. Okay. So sometimes it doesn't matter how well you fix it or how good a surgeon you are unable to give it a reasonable fixation which will allow you mobilization. Okay. So there is a role for a primary elbow arthroplasty in the elderly. Okay.
Yes,
So
sir.
I think you have to look at that. Knee also, some people would do it. We haven't done it, but there are some people who would. After all, why do you do an arthroplasty for a femoral neck fracture in the elderly? Because you know your fixation is very likely to fail. Okay.
Yes.
The
Yes.
literature shows that when you, at a certain age, above 65, 70, if it's a displaced fracture and you fix it, more than 50% are going to fail. Okay?
Yes, sir.
So it makes sense to do a primary arthroplasty. So similarly, some trochanteric fractures, not all, some distal humerus fractures, some proximal humerus fractures, okay? So where you might do a primary arthroplasty or today even a reverse shoulder arthroplasty. Okay, for very elderly patients whose rotator cuff is also gone, then doing a hemi doesn't work so well, so you might go for a reverse shoulder. Okay,
Yes, sir.
so that's the okay. Now,
What about wrist,
yeah,
sir?
so wrist, I think a lot of them conservative treatment works.
Okay.
Okay, so you can use distraction treatment using a distraction plate. Okay, or an external fixator. I don't think anyone does an arthroplasty for a wrist fracture. Okay, I think because usually you can get some kind of reduction and they manage okay. Even if the wrist is stiff, as long as the other joints are okay, it's not a major disability. I was going to say something else which you. So, okay, so early on there used to be the bag of bones treatment for the distal humerus, okay?
Okay.
Yeah, so where in an elderly patient, if they had a very distal fracture, because the techniques of fixation were not so good and arthroplasties were not an option, you would just keep them in a sling for some time and then start early mobilization. So they'll form a kind of pseudoarthrosis, which they could move reasonably well with. Okay, so that's again something that you might think of. Huh?
Okay, sir.
Okay, so there are various options and you need to differentiate different parts of the body because the treatment is not the same for every area. Huh?
Orthodesis also have some role.
Yeah, but you won't do a primary arthrodesis in any of these situations, okay?
Okay, sir. For exam purpose, we have to write options.
Well, that would be for the, at a later stage, salvage or something like that, yeah?
Yeah,
If it
yeah.
ends up with arthritis and things like that and painful, then an arthrodesis is an option. But I think very few fractures in the elderly that you would opt for a primary arthrodesis. Huh?
Okay, sir. No, one question I was asked previously that effect of alcohol on bone for short notes.
Yeah, so what do you think is the effect of alcohol on bone?
Don't know, sir.
Like both positive and negative effects.
No, so the problem is not, so it's not if you have one drink every other day or something like that is not going to cause a problem. The problem is alcoholism rather than alcohol. Okay?
Yes, sir. Yes, sir.
If you become an alcoholic, then it affects every system in your body. Okay?
Yes, sir.
Starting with your liver, your brain, your nerves, everything. Huh? So you
Yes,
can
sir.
write every part of it, and it also causes osteoporosis. Huh?
Oh.
Okay? It affects your AVN. Okay?
Yes, sir.
Chronic alcoholism can cause AVN, so then you end up with hip problems. Your liver can go, so everything associated with your bone metabolism can go. Okay?
Yes, sir.
So all
Yes,
the
sir.
things, so vitamin D deficiency will increase. All these things increase with alcoholism.
Okay,
But
sir.
it's not alcohol per se, but alcoholism, yeah?
Yes.
Okay, so if you have one drink in a week or 2 days or 3 days, there is nothing wrong in that. Okay?
Okay, sir.
Although in Bihar, you have to say that you don't drink if you are not allowed to. It's bad for your health.
Yes, sir. Thank you, sir.
Sir, almost everything is covered. Just one thing, sir, like bisphosphonate induced fracture, frequently asked in the exam, sir. Although it is a
So what did I
very
say?
big
That's a
topic.
different topic
Yeah.
altogether. Atypical
Yes.
femoral fractures. So we could do that in a separate lecture itself. It's not, because there are a whole lot of factors associated with it. It's for practical purposes, the only thing that one thing that you need to remember in terms of treatment of your osteoporosis is not to continue giving bisphosphonates for 10 years, 12 years continuously, okay? So usually now what they recommend is 3 years and then take a holiday.
Holiday period. Yes.
And for teriparatide, you tell that it is
Teriparatide, I think right now the maximum is 2 years or something like
2
that.
years.
in the
Yes.
lifetime, sir.
So actually you're supposed to give it for 1.5 to 2 years and then that's it. You don't give it again. Although I know people who've used it again, maybe after some time, but usually they say it's only a one-time treatment. Now you have denosumab and soon you'll have other drugs. So you have strontium. So you may have to change your medication after a certain time. I'm sure there'll be some new drugs out soon.
So, sir, is it increasing the T score, sir, or to maintain the T score? That
Don't ask me questions which you know the answer of, okay?
or DNB, sir.
Yeah, so I'm sure they know the answers of that as well. So I think the only treatment that has been shown to actually increase the score is what?
But I'm not sure, sir.
It's bisphosphonates, that too marginally, okay?
Okay.
So it's mostly
And
preventing
what is
progression. Yeah.
वो भी सिर्फ hip के round TS square का
Wait, that's what I'm
figure
saying. See?
spinal वाला था.
So the DNP people know the answer better than I do. Huh?
No sir.
So, okay, so I think that's what. So none of the others actually increases the T-score. I don't know about denosumab and all the newer ones might do. The combinations, teriparatide is the other one that does. Okay, but
Yes, sir.
how effective it is in actually increasing scores is not the issue. I think the thing you need to look at is how much it prevents fractures. Okay, and there are studies to show they do, but it's very difficult to honestly to have a really validated study for these. It's so difficult because so many factors come into the fracture other than just osteoporosis. It's balance, it's neurological situation, medication, situation at home, all these factors come in.
So,
Okay, I think we should call it a day. It's past 6:30, yeah? Okay?
thank you so much, sir.
Thank you, sir.
Thank you,
Okay,
sir.
thank you. Okay, see you next week or whenever.
Yes.